Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hi, this is Dr. Nick Biasotto, your host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. This is our new season, and this will be our first episode of the new season. And as you know, if you follow us, we have 37 episodes in our first season with very good exposure and many followers. And we hope they have been enjoyable to you in listening, so continue. We have more to come. We will continue to entertain and educate both the medical and non-medical community. Again, you can comment or ask questions by sending us your questions or comments, which we will air and answer in future episodes. So please send your comments to healthcare.reality@medsocdel.org. That's healthcare.reality@medsocdel.org. So, before I introduce my guest today on acute and chronic hearing loss, that is our subject, I would like to give a brief intro, and I would ask all non-medical guests to go to your search engines, such as Google, and type in the anatomy of the human ear, so you can follow and understand our discussion easily. So here goes. The human ear is a complex and interesting organ composed of three divisions. You have the first division, the outer ear, and this is the part that we all can see. It consists of cartilage and an ear, as you know, and a canal called the external auditory canal. It also includes the tympanic membrane, which is considered part of the outer ear, leading to the next section called the middle ear. The outer ear canal is what many of us use Q-tips to clean, but there's a saying that you do not want to put anything smaller than your elbow in your ear because the section of the outer ear called the tympanic membrane or eardrum can be easily hit and ruptured with a Q-tip, so please heed the warning. The second section is the middle ear. It's composed of partly the tympanic membrane or eardrum. This membrane is a thin piece of tissue that vibrates when sound waves hit it, and it marks the division between the outer ear and the middle ear. The middle ear is an air-filled space containing small bones, actually the smallest bones in the human body. They're called ossicles, and that's one, the malleus, also called the hammer. Why? It looks like a hammer. The incus, called the anvil, which looks like an anvil. And lastly, the stapes or the stirrup, and it looks like a stirrup which you put your foot in if you're going to ride a horse. The malleus attaches to the eardrum. This tiny bone attaches to the incus, which then attaches to the stapes, which then connects to the inner ear and carries the vibrations from the tympanic membrane or eardrum to the inner ear, or the next section of the ear we're talking about. Also, the middle ear also has a small tube called the Eustachian tube. I'm sure a lot of you heard that if you've ever gone to your doctor's office and had a problem with the inability to open that Eustachian tube. It gives a high pressure inside your ear, which hurts. That tube goes from the ear to the throat, and it keeps the pressure in front and behind the eardrum equilibrated so that the eardrum is not stressed by pressures without release. Now, the inner ear is where it all happens. You have the cochlea, which is a spiral-shaped, snail-shaped structure filled or lined with little hair cells, very tiny hair cells, that convert the sound vibrations into nerve signals to the section of the brain which interprets these vibrations and makes sounds that we hear. The second part of the inner ear is the vestibule. We're not going to talk too much about that today because we're really dealing more with hearing loss. But the vestibule contains the uticle and the saccule for detecting head position, linear acceleration, and the third section is called the semicircular canals. Now these are three little hoops in 90-degree planes that detect rotation, movement, or balance. So besides hearing, the ear apparatus helps to tell your brain, working with the eyes, where you are in space. If that gets messed up, you've heard of vertigo, and that's an inner ear problem due to a problem within the semicircular canals usually. Lastly comes the auditory nerve. That's the eighth cranial nerve from your brain that goes, or is also called the cochlear nerve, which carries electrical signals to the brain, interpreting the vibrations into sounds that we understand. So now that you know the anatomy of the ear, we are now going to discuss problems that may affect your hearing with our guest, Dr. Paul Imber, who will discuss acute and chronic hearing loss. Dr. Imber is a diplomat of the National Board of Examiners for Osteopathic Physicians and Surgeons. He is a board-certified otolaryngologist from the American Osteopathic Board of Otolaryngology. He received his education, his college degree from St. Joseph's College, and he received a B.S. He also received his doctoral degree from the Philadelphia College of Osteopathic Medicine. He was and had his internship then at the Metropolitan Hospital in Philly, and he also had his residency in Philadelphia at the Philadelphia Osteopathic Medicine in the Department of Otolaryngology, Bronchoesophagology, and Facial Plastic Surgery. His academic appointments are the Philadelphia College of Osteopathic Medicine Vice Chair and Clinical Professor. He's also of the Department of Otolaryngology and Facial Plastic Surgery from Drexel University College of Medicine at Hahnemann, and he's a clinical instructor there. His professional society memberships are in the American Osteopathic Association, the American Medical Association, and the American Osteopathic College of Ophthalmology and Otolaryngology, Head and Neck Surgery. He was formerly the president of the medical staff at Riverside Hospital. He was the president of Delaware State Osteopathic Medical Society. He is also president to 2005 of the Board of Directors of the American Osteopathic College of Otolaryngology, and he is presently the president of Delaware Academy of Otolaryngology at Head and Neck Surgery. If I was to read his entire bio, we would probably have to leave here by tomorrow. So it's a very impressive bio, and he's also published in many areas. Welcome, Paul.
Thank you.
All right, let's discuss acute hearing loss first, explaining what section of the ear anatomically is affected by each of the problems. So let's get going. For example, sudden onset, dealing with the outer ear. Talk to me about some of the acute processes that occur there.
Okay, so the most common acute process for outer ear hearing loss is usually, surprise, earwax, is cerumen. And if cerumen totally occludes the canal, then the patient will notice a subjective hearing loss. Usually it's anywhere from 30 to 60 decibels of loss, 60 being maximum. And if they have even a pinhole of opening, they may have a ton of wax, but if there's a pinhole of opening, sound will get through and the patient doesn't feel the hearing loss. So it really has to be pretty occlusive to make that happen. The most common cause of that happening is a patient using Q-tips in their ear. Because the Q-tip not only has potential damage to the tympanic membrane, but it pushes the wax in. It doesn't pull it out. So I often liken it to a front-loading muzzle gun from the Revolutionary War, and you're just pounding that gunpowder down the barrel of the gun, i.e. the cerumen down the barrel of the external auditory canal, and that just packs it in and puts it up against the drum, making it really very uncomfortable and difficult to remove.
Okay, now, you just discussed something acute. Is there any other acute problems with the outer ear which can occlude hearing? For example, maybe swimmer's ear. Does that ever get that bad?
So if you have an acute otitis externa, outer ear infection, generically referred to as swimmer's ear because usually it's due to water exposure but not exclusively, that can cause the tissues, the soft tissues of the outer ear canal to swell, become edematous, and that can get to the point of occlusion in many patients. When that happens, in order to treat that, just putting eardrops in or taking an antibiotic by mouth won't be enough. You actually need to do some level of cleaning of that canal so the medication can get where it needs to go, and then you need to put a wick, a little tissue in, either a sponge or a cotton ball rolled up, to help to carry the medication down, and that'll gently take the swelling down and get the medication where it needs to go.
Okay. Now, I guess that's all for the external ear, would it not be, or is there anything else?
Well, for acute, yeah, that would be about it.
Okay, now let's move to the middle ear. Can that cause acute hearing loss if there's something wrong in the middle ear, where the little bones are and the like?
So acute hearing loss in the middle ear can be a variety of different things. One can be the classic Eustachian tube dysfunction. So Nick very well described the Eustachian tube as this thin tube that connects the middle ear to the back of the nasopharynx and the back of the nose. That middle ear is a very unique anatomic location in the body. It is the only air-filled cavity in the body that doesn't have an escape valve that's opened all the time. So the Eustachian tube is closed at rest. And when you swallow or you yawn, there's a little muscle called the tensor veli palatine muscle that pulls down, and that helps to open the Eustachian tube. If there's any swelling in the tube due to upper respiratory tract infection, allergy, coming off an airplane, and you have some barotrauma from the airplane, and that causes some edema in the area, and you all know that feeling of coming off that plane and waiting for that ear to pop, and it may take a day or two for that to happen. That's the circumstance of Eustachian tube dysfunction. So that certainly can be a problem. Acute otitis media, an acute middle ear infection, causes fluid to build up in the middle ear because that negative pressure isn't being cleared. And as that fluid builds up, it gets infected, and that can cause significant hearing loss and significant pain as well. And then there are other issues that can cause middle ear acute hearing loss, so trauma. You can be riding your bike, get knocked off your bike, hit your head, and you can fracture one of those joints of the three bones in the ear. You can get a fracture. Usually it happens at what's called an lenticular process, which is the long arm of the anvil as it goes to the stirrup, or the incus to the stapes, and that incus-stapedial joint can become dislocated, and you can end up with a conductive hearing loss as a result of that. The important thing to remember is the external canal and the middle ear, that hearing loss is a conductive hearing loss. And if you like, we can start to talk about the difference between conductive and sensorineural as we get into the
You got it.
into the
Okay.
internet.
We will move on. Okay, so I have a blocked off Eustachian tube. I can't hear and I can't pop it. And you know the feeling, any of those who've been on a plane or any kind of altitude where your ears just won't pop, that becomes uncomfortable. And it can be painful. And as you pointed out, it could cause a hearing loss because of that mess up of the conductive system. Now, I'd like to move from that to chronic hearing loss, and then we'll talk about sensorineural as we go. Okay.
Okay.
All right. So, tell me a little about chronic hearing loss. It's long term. It develops slowly. Tell me a little about it.
So chronic hearing loss is long-standing hearing loss. It's something that didn't happen suddenly. And usually it's a slow progressive process, but as we're talking about chronic hearing loss related to the outer ear and the middle ear, for the outer ear, chronic hearing loss would be the congenital atresia of the ear canal.
In other words,
Somebody
it's
who's
not
born
developed.
without an ear canal.
Right.
They have their auricle, the little flap on the outside of their head, that's malformed and misshapen, microtia, decreased size. The canal may not have been developed. The bony canal may be fused shut, and that can be obviously a reason for conductive loss in that area. It may relate to other anatomic deformities congenitally in the inner ear as well, or it may not. In the middle ear, chronic hearing loss is usually due to persistent and recurrent ear infection, and they have a persistent middle ear effusion fluid in the middle ear that stays a long time. That can usually be corrected surgically with Myringotomy and tubes, ear tubes, as the kids usually refer to it. The other issues are that chronic infection can also, and inflammation can also lead back to inflammation in the mastoid air cells, which are air cells behind the ear, kind of like sinuses attached to the ear. And then you can end up with having unusual growths and inflammatory growths like cholesteatoma, which is a growth and actually erode bone. And it can erode the ossicles, it can erode the middle ear bone, which contains it, into the skull, and sometimes can erode up into the brain and end up with a subdural abscess.
Right. Cholesteatomas we picked up in the past, and they can be pretty significant. I always liken to the fact that when I bring the kids in, because Mom says, this is his 5th ear infection in a year, I worry about potential hearing loss. And that's when I refer to you guys to put in some Myringotomy tubes, or ear tubes as the kids call them. It's a rather simple procedure, I take it, where you do the draining of all that infected material, put in a little tube that allows drainage to come out into the external canal.
Yeah.
And that keeps the ear from being destroyed by chronic infection. And it can also affect a child's hearing. If mother comes into the office and says, he's just not talking right, something's wrong, you look in the ear, you may not actually see anything, but you know there's a problem. And you do some hearing tests and you realize they've had chronic infections that have destroyed the middle ear components, correct?
And that can happen. Usually when you're looking in the ear, you'll see something. You'll see fluid, you'll see retraction, you'll see a dullness to the tympanic membrane. It won't have the normal translucence that it has. But that's more a trained eye. Someone who looks at ears all day, and you're looking 30 pairs of ears every day for a lot of years. You kind of know what you're looking at.
Exactly. I always worry about children as they develop this. They can't speak right, or they're seeming to having to put the TV up louder so the child can hear it, that they do have a problem. Okay, I'd like to take a break right now. We'll be back after the break, and we'll continue with this interesting discussion with Dr. Paul Imber regarding acute and chronic hearing loss. You're listening to Delaware Healthcare Reality, the podcast of the Medical Society of Delaware.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Tell me a little bit about sensory neural hearing loss and generally what's causing it and how it occurs and how it leads to really big problems.
Okay, so when we talk about hearing and hearing testing, there's conductive hearing loss and there's sensory neural hearing loss. Basically, when we do a hearing test, we can put sound in from the outer ear canal with a set of headphones, and the patient hears through the full auditory system. But we can also bypass the outer and middle ear by stimulating bone conduction, or the bone behind the ear over the mastoid. Some of you may know about bone headphone speakers. A lot of athletes like to use them when they're riding bikes so they can hear what's going on around them, but still listen to their music. So they're available out there. They're pretty cool, actually. And what happens is if you vibrate the bone of the skull, the cochlea, the inner ear, picks up that stimulation, and it will transmit the sound to the brain. So if you have a patient with a conductive loss, putting sound in from the outside, the hearing will be diminished. But when you bypass the outer and middle ear and stimulate the inner ear directly over the mastoid, they'll hear fine. So, for example, kids who have middle ear infections, mom's worried he can't hear, everything's awful. As soon as you put that vent tube, that pressure equalization tube, into the eardrum and get the fluid out, within 2 to 3 months, their hearing is pretty much back to normal again because the fluid's out and everything's running normally again. You can predict that because their bone conduction is normal and you know the inner ear is working okay. So sensory neural hearing loss is where the hearing loss is the same whether you go from the outside in or from behind the ear in. That's the sensory neural loss. It's there all the time. That is due to damage to the cochlea. And Nick very nicely described what is known as the organ of Corti, the little hair cells that sit on the basal membrane and the cochlea as it does its spiral turns. Physiologically, what actually is happening is, as it goes through those turns, each distance along that little membrane are bundles of hair cells, frequency specific. And those frequency-specific hair cells vibrate And I like to compare it to like a transducer, and it turns the mechanical energy of vibration into a chemical electrical impulse that stimulates the nerve and carries the impulse to the brain. And so damage to those hair cells is usually where the injury occurs.
Okay. I'd like to just add one thing, that sometimes the doctor in his office may take out a tuning fork and do what's called the Rinne or the Weber test. Now, they would put the tuning fork on the back of the mastoid, and the kid hears. And then they look at the Weber test, and they can't hear it through the ear itself. That tells you it's more of a conductive hearing as opposed to sensorineural.
Correct.
Okay. All right. Well, let's talk a little bit about that sensorineural hearing loss. And how did I become deaf, let's say?
Well, so acute hearing loss of the inner ear usually is due to acoustic trauma. Mm-hmm. That's the classic cause of it, most likely. So everybody's been to a concert one time or another in their lives, and they walk out of the concert at the end of 3 hours of blaring music into their heads, and everything is muffled. It's dull. And suddenly you have this ringing that you never had before that you start hearing. And it stays that way for a day or two or three. If you're going to a gun range and you're foolish enough not to wear headgear, which I think is almost impossible to do anymore, but if you do that, or you're shooting a weapon that's much more powerful than your ear protection is able to handle, and you don't have any type of silencer or attenuator on it, you will have the same thing happen. Any acute trauma, so you can go to fireworks. You're walking down the street and some kid throws a firecracker up and it blasts next to your head, and suddenly you have this loud blast and you can't hear for a while. That's acoustic trauma, and that's the most common cause of acute sensorineural hearing loss. Now, physical trauma can do it as well, but it has to be a pretty significant trauma. You have to have basically a basal skull fracture that cuts through and maybe cut through the superior aspect of the inner ear, of the skull base, and that can cause hearing loss as well. But if that's the case, the hearing loss is the least of your worries at that point.
Okay, I'll just bring up one of the things that happened to me in my day. I went to an Emerson, Lake and Palmer concert. When I came out of that concert, I couldn't hear for a half a day. I heard nothing. Guys were talking to me, and I had to read their lips. They were laughing too, but they couldn't hear very well either. So sound trauma can be a big cause of hearing loss. But did that sound trauma that I experienced at that day produce anything that would give me a sensorineural loss in the future, or did it do it already?
So it's an accumulative event.
Okay.
So to put it into very realistic terms, I used to be the house doc at the Spectrum in Philadelphia for 4 years.
Then I was there probably when it happened.
It's probably that concert. And I used to work 2-3 events a week during my internship and residency as the house doc. That's how I managed to maintain my lifestyle.
Okay.
And I always wore ear protection, being an ear, nose, and throat resident. I kind of knew, and I had ear molds made and everything else. But today, I have a chronic sensorineural hearing loss with tinnitus. I wear hearing aids. They're wonderful, by the way. And certainly, it's an accumulative event over time. The military, big lawsuit, because there was a big issue whether the 3M earplugs were sufficient for what the kids what the military soldiers were using. And there's a big lawsuit, multi-million-dollar lawsuit that's going on now, still working through because of long-term noise exposure. So it can be working in a machine factory, it can be being a car mechanic, it can be gardening tools and hand power tools. It's an cumulative amount of noise going into your head. Kids wearing headphones and turning their AirPods up. If the person sitting next to you can hear the music, it's too loud.
True. And boy, do they like it loud.
Yeah, and they're going to pay the price. Eventually down the line,
it will do its damage.
They're going to pay their price.
I see sometimes I'm behind a car where they have their music speaker on so loud you can actually see the back of their window vibrating. Yeah. And I just say to myself, boy, give them a few years and they're going to be sorry they did that. Okay, you mentioned tinnitus or tinnitus or whatever. You say potato, I say potato. I get the constant question from a patient. I got this ringing in my ear and it won't go away. What can I do? Is there any treatment for tinnitus?
So first you need to we try to understand what tinnitus is coming from.
Good.
So tinnitus is a hallucination of a sound. Usually it's a very high-pitched vibratory sound. Sounds like a fluorescent light when it's about to go and you get that hum.
Mm-hmm.
One patient this morning described it as when the TV used to go off the air in the old days at like 1 o'clock in the morning, and he had just put that alert signal on you to show that high hum going through the TV. The concept of tinnitus that we're working with today, and it may be wrong, but the current concept is, I like to describe it as the nerve is no longer receiving a signal. And the on-off switch ends up getting turned on instead of turned off. So I liken it to phantom limb, where a person has a leg amputated and they feel pain in the leg that's not there anymore because that sensory nerve for pain isn't getting any stimulation and the brain interprets it as a constant stimulation. And usually when we do our hearing testing, we'll see where our maximum hearing loss is, usually around 4,000 or 6,000 hertz. And that's usually where they're hearing their tinnitus, where the maximum damage is.
What, I didn't hear that. Say that one more time.
So usually tinnitus will occur where their hearing loss is the worst.
Okay.
So when you look at your audiogram and maybe you have 30, 40 decibel loss going across in the low and mid range, but in the real high range, it drops off to 60, 70 decibels. The ringing is going to be usually up in that 67, that high range area where they have the loss. And this, of course, is a constant, steady, humming, buzzing sound that is usually noticed primarily when you're in a quiet setting. And the reason for that is because, remember I said there are multiple hair cells at each frequency. Not all the hair cells are damaged. So the hair cells that aren't damaged at those frequencies are still working. And when those hair cells are stimulated, it overrides the ones that are constantly on, and it all kind of blends in, and now you get what we call tinnitus masking. So the first thing you need to do if you have tinnitus is get a hearing test and find out what your hearing loss situation is. Many times, if your hearing loss is significant enough and the tinnitus is annoying enough, hearing aids will help to not just improve your hearing, but they will, and social skills, by the way, but they will also help to mask that tinnitus.
Okay.
More simplistically, if you're just at home at night, you have a hard time falling asleep because you have that buzzing in your head, I usually tell patients, pick up a noise generator. Either white noise or environmental noise generator. Listen to the rainforest or the ocean or any of those things that probably have an app on their phone that'll do it for them. And the whole purpose of that is that helps to override, to mask that ringing. Some patients find a fan in the room is all they really need. One thing you don't want to do is leave the television on. That really ruins and fragments your sleep, and the blue light is awful, and you really don't want the TV. Jazz music is good because it's unstructured and has good variability, so if you want some nice mellow jazz, that's fine too, but that usually helps to block. We can also do tinnitus matching, so we can find out exactly where your tinnitus is in terms of frequency, and we can develop what's called a tinnitus masker that you wear like a hearing aid that will actually put out the opposite sound to negate the tinnitus, and that can help to block also.
Okay.
There's a lot of work being done on cognitive behavioral therapy for tinnitus, because the key to tinnitus is really you learn to accept it. And that's what comes down to.
There's no magic pill. There's
no magic
vitamin.
pill.
I've heard in the past lipoflavonoid, B6, blah, 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 and people try it and say it doesn't work. I said, it's not going to.
Yeah. So the only thing else I will tell patients to do is use some magnesium glycinate. And magnesium glycinate is a neuroprotective mineral. It works well for helping you to sleep better. It's good for cramping of the muscles. And there are some studies that show that it may be otoprotective in a noise environment setting.
But if you have it already, the tinnitus, taking magnesium may or may not help? What do you think?
Some patients say it does, some patients say it doesn't.
Got it. Okay.
To put it in perspective, I take it every night.
Okay. Does it work?
I think so, yeah.
Okay, I'll have to remember that
Yeah,
one.
400 milligrams for men, 300 for women, magnesium glycinate.
Very good. Talk to me about otosclerosis. That's another hearing loss sensor.
So otosclerosis is interesting. So otosclerosis is really not otosclerosis. It's really otospongiosis, but fine-tuning. That is a deformity in the middle ear where the stapes, that little stirrup, fits in to the oval window and
of the cochlea,
which is the entrance in, and that foot plate fixates onto the bone, so it doesn't vibrate well. It's often genetic, it's often hereditary, more common in females than males, usually exacerbates with pregnancy. So if you have a female patient who has otosclerosis, you'll usually find that there's one or two members of her family that have it as well, not always, but you can. And they've usually had surgery to correct it. The surgery involves bypassing the stapes and going back into the oval window with a prosthetic or lasering the foot plate. And if a patient has it bilaterally, usually you do one ear, but you won't do the second ear until after they're done having children, because you don't want it to exacerbate with more pregnancies. Mm-hmm. And I don't know if there's a hormonal component to that or not. I really don't know, but that's the story with otosclerosis.
Good. Now, I've had patients with Meniere's disease. Now, Meniere's disease sees the triple play, the home run of hearing problems. They have hearing loss, vertigo, and tinnitus. What causes that?
So Meniere's disease is actually a trash can diagnosis. It's when everything else comes back negative, we call it Meniere's disease. So Meniere's classically is a disease of remission and exacerbation. So patients will have an acute episode. The acute episode will be, and is almost always unilateral, and the acute episode will be a severe fullness in the ear and hearing loss associated with that, ringing, roaring tinnitus, and spiraling
periodic
vertigo.
Mm-hmm.
Just, nausea, vomiting, the whole thing. It lasts several days. It usually burns itself out, and then they're good. And they may be good for a month, they may be good for a year, they may be good for 2 years. But the next episode usually happens a little bit sooner. And each episode comes up a little bit sooner by the classic definition of Meniere's disease. The concept has always been that Meniere's was due to an increase in pressure in the endolymphatic sac, in the inner ear. The fluids in the inner ear have increased pressure. And there were hundreds of procedures that were tried. They tried putting tacks in to pop the sac when it swelled too much, and it would help to drain it. They tried doing horizontal cryolabyrinthectomies and all kinds of different things people tried. Unfortunately, because of the rareness of the real disease and the remission and exacerbation, there's really no great cure for it. Intratympanic steroids can be helpful for some patients during the acute phase, medication to get them through the acute phase. Some patients, some doctors actually believe that Meniere's is probably an atypical migraine.
Huh, interesting.
And they relate that whole thing to a migrainous event.
And
they'll use migraine medication.
And does it help? Have you seen the success of that?
Again, with the remission and exacerbation, it's hard to know what's going on. Uh-huh. But one of my partners, Mike Teixeira, is renowned around the world talking about migrainous vertigo and migrainous tinnitus and migrainous Meniere's. And he has a lot of success treating it like migraine. So you can use migraine preventative medications, and of which there are a variety and numerous choices. And I suspect in the acute phase, you can probably use acute interactive medications at that time as well.
I've referred to Mike Toshido numerous times for those who've had persistent and regular vertigo off and on for no particular reason that I could help or fix. And he does a really good job in helping it out. I imagine he gets dizzy with all the work he has to do. Okay. Now, presbycusis, the aging ear, is that just because of the cumulative effect of noise over the period of time, or what?
Combination of noise and blood flow.
Okay.
So as we all develop atherosclerosis of some degree or another, and we all get an MRI scan and see little punctate dots going through the brain as we get older, because that's the nature of the beast.
Yep.
That's living in the Western world. We end up with ongoing damage to the inner ear from that, and that's presbycusis.
Got it.
It's a slow process. Patients don't realize what's happening because they're accommodating to it each day, each month, each year, and almost everybody comes in with the same complaint. I hear great, my wife's complaining. I hear great, my daughter's complaining, whatever it is. The kids mumble today. They don't talk the way we used to talk when I was a kid.
There you go.
It's always that. Well, then you start asking the questions. You find yourself asking for repetition, asking people to repeat themselves more often. Yeah, but it's the way they talk. Okay. And so you find yourself turning the TV up, the volume up a little bit.
All the time.
That little volume button is moving across from 10 to 20 to 30 to 40 over the past 10 years. Yeah. And using closed captioning? Yeah, I started using that. I like using closed captioning. And that's the story. They end up with presbycusis.
Got it.
The problem with it is, left uncorrected, it can lead to a lot of different problems. And so it's really important that the hearing loss be identified, and that if you do have significant hearing loss, as determined by the audiologist and the otolaryngologist, that you choose to go forward and go to corrective measures. The importance of corrective measures is, A, you're going to hear better, but B, you're going to be more socially interactive, especially with elderly patients. When you can't hear, you tend to withdraw. Mm-hmm. And the more you withdraw, the more you hide inside yourself. And there are statistical data internationally that shows sensory neural hearing loss in the elderly patient left uncorrected significantly increases memory loss
and
dementia. And actually, I just saw a study referenced from Hopkins that was done about 10 years ago, that the fall rate goes up significantly with every 10 decibels of hearing loss.
Interesting.
So for quality of life in your senior years, you want to identify that hearing loss and get it corrected.
Yeah, you want to do that because that's one of my workups for dementia, because I've read that myself. 60% of an effectiveness from hearing loss could be the earlier causes of dementia because of the withdrawal, the inability to communicate with each other. You get lost for other reasons. So it's an interesting thing how the ear plays into that. All right. Now, there's a couple of things I've seen about the genetics of hearing loss. For example, there's one syndrome called Alport syndrome, which is renal failure and hearing loss. Now, how in the hell does that relate to anything, and how does that fit in the system? I'm not sure.
So Alport syndrome is a genetic disease that affects kidneys, hearing, and the eyes.
Yes.
And it's due to abnormalities in the type 4 collagen, which is a structural protein in the basement membrane of tissue.
Okay.
So part of that basement membrane of the ear and the kidney and the eye are made up of these type 4 collagen, and depending on the genetic abnormality, and they, of course, with all the gene testing and all the great stuff they're doing with that, with gene evaluation, chromosomal evaluation, they can actually identify the exact gene and the location where the problem is. 80% are X-linked, male-based, and they lead to a weak, irregular basement membrane in the kidney. And thus there's progressive kidney damage that goes on with these kids over time. Usually they have earlier kidney failure requiring dialysis or transplant. and will also affect the cochlear and ocular basement membranes as well.
It's not very common, though. I've only had, in my 40-year career, 45-year career, only 2 people that had that.
Yeah, it's very rare.
Okay. Any other genetic situations you know of?
So there are a lot of other genetic situations. There's something called Waardenburg syndrome. That's an autosomal dominant disease that actually shows up with a varying phenotype. So the genotype is having this Waardenburg syndrome, but the way it appears on the body is a variety of different things. So it can be a progressive sensorineural hearing loss through teenage years. It can be 2 different color eyes,
Okay.
heterochromia iridius.
Uh-huh.
You can end up with a white forelock, so a flap of hair in the front of your head that's white and doesn't accept a dye.
Right.
You can't dye it. Mm-hmm. And you can also get hyperteliorism, where the eyes are wide set. Kind of like a Down syndrome eye would be wide set, but they don't have Down syndrome. Uh-huh. And you can get any 1, 2, 3, or 4 of those things. And usually if a patient presents and you think that's what they have, you start asking about family members and say, oh yeah, Uncle Joe has that white forelock thing, and my cousin has 2 different color eyes. Oh, wow. And
I wonder if David Bowie had that. He had 2 different color eyes. Interesting.
Could be.
Okay, they're very rare.
Yeah.
So I'm sure not too many times. Have you seen that? Okay. Are there any autoimmune diseases that you could name that could cause this?
So the next thing that really we should talk about, because it's really important, is acute idiopathic sensorineural hearing loss. So this is a patient who wakes up and suddenly their one ear feels full. Their hearing is diminished. They may have ringing. They usually don't have dizziness with it. And they're not sure what's going on. And, well, I'll give it a month and see what happens. Mm-hmm. Maybe I have a cold. Sometimes they go to the medical aid unit. The medical aid unit looks and says, maybe it's Eustachian tube dysfunction. Mm-hmm. Well, here's some steroid. Here's some decongestant and nose spray. Mm-hmm. Let's see if that helps. This is often a autoimmune or vascular etiology to this, and the problem is, as time goes by, the likelihood of recovery goes down. Uh-huh. And so this is actually pretty close to an otologic emergency, and that this is a patient who should be seen within a week or so of their hearing loss. Mm-hmm. Because high-dose steroids can reverse the process systemically, and or transtympanic steroids or intratympanic steroids, injecting steroids through the eardrum into the middle ear and letting it soak through the round and oval windows into the cochlea, can help to reverse the process, and usually a little better than 50% can get recovery. Mm. And unfortunately, the patient comes in 2 months later and says, oh yeah, I think I have wax in my ears, and they never went to anybody, and the reality is they have no wax. They have sensorineural hearing loss unilaterally due to this problem, and it's too late. There's not much you can do about it except for amplification and treating around it.
I have a friend, a patient, and a doctor. He's the same person, and you know him too, who has autoimmune bilateral hearing loss.
Yeah.
Had it since he was in his late 30s, I believe it began. And that was going to lead us to just one more thing is on sensorineural hearing loss. Some of the medications that we've used in the past, aminoglycosides, can destroy. How does that work to destroy hearing?
So medication can cause damage to the ear. And the big ones that I always think of, Nick just mentioned the most common antibiotics, which are the aminoglycosides, gentamicin, streptomycin, neomycin, vancomycin. And these are all antibiotics that are still being used on different occasions for different purposes. But when used systemically, you really need to get pre-use audiograms and get some hearing testing while you're using the medication. You need to do peak and trough studies, blood studies, to see how much of the antibiotic is in the system. You want to keep your peaks down as best you can to minimize too much stress. And this is just the drug kills the hair cells.
Okay, that's how it happens, hair cell destruction.
Yeah, it just destroys the ear.
Got it.
Other medications are anti-cancer drugs, antineoplastic drugs like cisplatin, and like medications, and those should be monitored as well while being used. Lasix is a well-known diuretic, furosemide, used for a lot of different things, but in high doses, furosemide can cause sensorineural hearing loss. It may be reversible, it may not be, depends on the patient's response and how long they've been on the medication. So there are a lot of different things you got to be careful about with medications. Aspirin, solicitism, high-dose aspirin use before we had Tylenol, acetaminophen, and the ibuprofens and non-steroidal anti-inflammatories. People used to pop aspirin left and right. It wasn't uncommon to have a patient taking 650 milligrams of aspirin 4 or 5 times a day. And over an extended period of time, solicitism kicks in and it can cause hearing loss.
So medications can do it, but sometimes you need to use them quickly, so you can't do that pre-test and then post-test and monitor it, so you got to keep them out at a certain rate. Now, we talked about that patient, my friend, my patient, and a doctor who lost his hearing through autoimmune disorders and ended up with a cochlear implant. Now, let's go into the treatment for hearing loss. That's extreme treatment. Tell me a little bit about hearing aids.
So hearing aids are the first line. If you have a very mild hearing loss, you can get away with using, so for example, AirPods have now come out with a hearing aid mode in the AirPod. So if you want to try that, see how it works, it's more of an amplifier in that it just makes sound louder. It's not frequency-specific modulation. There are over-the-counter hearing aids, which have some good computerization and AI built into them. They usually run anywhere from $200 to $2,000, depending on what you get. But they're also, some of them are partially programmable. They're really for mild to moderate hearing loss, and that's how the FDA approved them. The hearing loss that's anything more than that, or that has some really specific frequency issues to it. So, for example, your low-frequency hearing is perfectly normal, but your mid to high range slopes off significantly into a moderate or severe level. You can't just turn the volume up. If you remember the old stereo systems that had equalizers on them, and you could frequency-specific increase in range the bass and the treble and what you wanted to boost and tone down. If you're a sound engineer, certainly you understand that. Basically, the hearing aids do that. We can program your hearing aid for your hearing loss, and hearing aids come behind the ear. They go in the ear, depending what you want. I prefer behind the ear because you have more space to put more computer chips in, and you can do cooler things with it.
Okay.
So, my hearing aids Bluetooth to my telephone. They work like AirPods that way, so I can answer my phone with my hearing aids. Nobody else has to hear my conversation, or at least the other end of it. I can play my Pandora and, listen to music while I'm working out in the yard, and it's just a natural, very easy thing to do. They also have filters on them that are pre-programmed. So if I go into a restaurant and the background noise is annoying, I hit restaurant mode, and it tunes out the peripheral sound and it increases the sound of what's happening in front of me.
That's what I hear about hearing aids that people don't like. They can't get rid of the background sound,
right.
So they can't hear. They still
so
can't.
The newer aids, particularly because of directional microphones and artificial intelligence, really do a great job with that. They also have TV mode, music mode. I go to Eagles games all the time. I'm sitting in the stands. I'm not overwhelmed by the crowd noise because the AI in the aid modulates that down and keeps that sound down, but lets the voices come through. So
it's like the little muscle that attaches to the. There's a little muscle.
It's called the stapedius.
Stapedius that attaches to the drum.
Well, it doesn't. It actually attaches to the
incus.
To the incus. It's
yes.
the incus-stapedial joint, and
so
the stapedial tendon hits it, and that's a reflex arc. So it's 8th nerve in for sound and 7th nerve out for the stapedial reflex, and we call it the acoustic reflex. We can actually test for it with our hearing testing, and so when loud noise is exposed, the ear is exposed to loud noise, that stimulus goes up, the reflex arc comes down. The tendon contracts, It adjusts the modality of the three bones in the middle ear.
Interesting.
And it dampens the sound by about 20, 30 dB and really helps to modulate the sound and protect the ear from loud noises to some degree.
Right.
Some patients who have that not working well for any one of a variety of reasons will complain of hyperacusis,
Right.
where loud noise is very bothersome to them.
Because they can't attenuate
Because
it.
they don't attenuate those bones.
Wow, that's pretty interesting. That little ear is so...
A lot going on in there.
So busy. Okay, now, I talked about our friend who I referred you to, and did
Yeah.
end up with a cochlear implant. That is an interesting progression in the treatment of complete hearing loss. Now, explain to me how it occurs so that people understand how the surgery works and what it does.
So this isn't a procedure I do, but I have two partners who do it. Basically all the cases in the state are done by these two doctors or one of the otologists at DuPont and Moore's for the kids. And basically, they're taking an electrode, they're putting it into the inner ear, into the cochlea, and running it along that basilar membrane. And then that electrode sticks out behind the back of the ear. They have a box that sits on top of that. And as sound comes in, it stimulates electrically those electrodes to stimulate the base of the organ of corti, of the hair cells.
Okay.
So it bypasses the hair cell and it goes right to the nerve. The good part about it is, I don't know, they were up to 23 channels. I don't know how many channels are up to now. So our speech range is usually about 250 hertz to 4,000 hertz is the majority of our speech.
200 to 4,000.
Yeah, and that's the range of our speech. At the office, we check up to 8,000, 16,000 sometimes. But that's a different situation. Our actual speech, of human speech, is usually 250 to 4,000. Well, that's 3,750 different hertz that we got to adjust for. Obviously, we can't do that. But we work with a range. And so you get improved hearing, you get pretty decent word recognition. So patients can, say the word, repeat the word. They get good comprehension. It's best in patients who have had hearing before, because they know what they're looking for. Usually the patient, by the time they get to that point, is a pretty well-trained lip reader. So he already has really good lip reading skills. And the downside is you really don't appreciate music the way you would appreciate music. It doesn't have that fullness to it. But compared to not hearing it at all, it's certainly great. And the most important thing with both hearing aids and cochlear implants is the safety of it. So many of our alarms are 3,000 to 4,000 decibel alarms, which are in the higher frequencies. And if you can't hear your smoke detector going off,
there's a problem.
You're screwed. You're in danger. So if you can't hear the horn honking behind you when you're driving, you're in big trouble. So from a safety perspective, it's very helpful. When they first came out with cochlear implants, it was like a 1-channel and a 5-channel, and like all they heard was noise.
Right.
But it was safety, and that was the key for it at that time. Now it's gotten much better, and I would imagine it's going to continue to improve as time goes by. He has
had significant hearing improvement. I don't have to repeat as much with him. It's really nice. He's a good friend of mine, too. All right. Now let's move on to the last subject of a new research project that's going on in the UK. It's on a research into what's called Rincell, Rincell1, in which they supposedly inject stem cells into the cochleus to regenerate the hair cells. Tell me about what you know about that.
So stem cells are multipotential cells, and everybody has them. Actually, they're pretty predominant in the salivary glands. And a multipotential cell is a cell that can turn into a lot of different things depending on the environment that it's in. And so you use stem cells, they inject them in the knees, and theoretically they're going to help to grow cartilage. and help to minimize degenerative disease, joint disease. In this case, they're doing some research with rabbits and chinchillas, I believe, and injecting the stem cells into the cochlea with the hope that it's going to regenerate basically the organ of Corti, those little hair cells.
Right.
And so with electron microscopy, they're finding some success with that. They don't know what it's going to end up meaning clinically. Obviously, you can't do electron microscopy of the organ and then see if it works or not because the specimen is dead to get the electron microscopy. So that ship has sailed. But I'm sure, this has potential, no question, for further development. And hopefully, gene research may come up with something where chromosomally we can say, hey, patients who have this particular chromosome abnormality are more prone to have presbycusis, and if we can correct that genome, maybe we can correct that problem too. We'll talk in 20, 30 years.
Yes, way beyond us, I think. I told my buddy about it because he has one of the criteria for the research in this Rinne cell 1 is people who have had cochlear implants. They actually follow the nerve of the electrode right into the cochlea and stimulate the cochlea with their stem cells. Very interesting. It's being done in the UK. I'm just curious to see where they get with it. It's in, I think, phase 2 trials at this point, which is very good. I have to say, Paul, this is one of the most interesting of our podcasts that I have heard in the 37 that I've done. It's a pleasure having you here. I am so thankful that you have come and give us a good information about a very common problem, and that is hearing loss. And he is a member of a physician practicing in ENT and Allergy of Delaware, which is a large group of ear, nose, and throat physicians who can help you with any of the problems we have spoken here about today. This is Dr. Nick Biasotto signing off. I hope you enjoyed this. And again, this is the sponsored MSD podcast, Delaware Healthcare Reality. We'll be back with another topic in a few days. Bye.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.